Good evening everyone. Welcome to the last session of the day. तुम्ही सगळेच कंटाळलेले असाल. मी तुमचे फक्त 20 मिनिटं घेणार आहे. बट आय वॉन्ट युअर फुल पार्टिसिपेशन. हे शाळेसारखं लेक्चर असणार आहे. सो आय वॉन्ट युअर पार्टिसिपेशन. आणि सगळ्यांनी 20 मिनिटं लक्ष देऊन लेक्चर ऐकायचं. ॲट द एंड ऑफ द लेक्चर विल हॅव अ स्मॉल क्विज आणि त्याच्यानंतर सरप्राईज गिफ्ट्स असणार. सो प्लीज पे अटेन्शन फॉर द नेक्स्ट 20 मिनिट्स. I have the tough job to teach you how to treat seizures perfectly in 20 minutes. So coming to approach to management of seizures. So I'll not be dealing with any theoretical concepts, no definitions, no complicated flowcharts. I'll be just giving you practical tips to better the outcome in patients presenting with seizures. So this is how we are practicing, me and you right now. Be it any kind of seizure, be it generalized tonic-clonic seizures, be it focal seizure or absent seizures. There's only one drug we are using practically, and that is levetiracetam. That is practical. And this is a joke which is famous among the neurologists. Seizure is not a symptom of Levipil deficiency in your body. So Levipil is the easiest thing for the doctor, but definitely not the best thing for the patient. And that is the importance of this lecture. So I will be discussing management of seizure in the OPD, in the emergency, in the ICU. I'll be dealing with choice of drugs according to the type of seizures, role of polypharmacy, contraindication to drugs, and when and how to taper and stop drugs. So why is this lecture important? There was a very large trial, that is emergency management of status epilepticus treatment trial. This trial mentioned that 75% of the patients who had landed into status epilepticus had received inadequate dosage of anti-epileptic medications. So if we loosely see, 75% of patients in status epilepticus were iatrogenic, they were created by us. And if we give right dosage of anti-epileptics, at least 50% of these patients we can prevent going into status epilepticus, and that is the importance. I have a small request, everyone, if you just scan this QR code immediately. We'll have a small demo question after this, and the same QR code we'll be using for the quiz as well. Accessible? Really? Sure. Connect to Wi-Fi. Yeah. So we'll go ahead. We have a 56-year-old man, diabetic hypertensive on treatment, while sitting in the OPD waiting area becomes unconscious with jerky movements of limbs and a tongue bite. So obviously he has had a seizure, which is ongoing for 2 minutes. So what is the next step we'll give? You can vote on your mobiles if the network is there, or you can shout out. Very good. Very nice. So we have had 12 responses, 14 responses, most of them choosing nasal midazolam with checking sugars immediately. I'm happy most of them have chosen the right answer. So it is very important to check sugars immediately, and that is the first lesson. Always check sugar simultaneously when midazolam is being loaded or is being prepared. Make sure your OPD is equipped with a midazolam nasal spray for emergencies. There's no role of anti-seizure medications as a first step in actively seizing patients. No valproate, no levetiracetam, just plain and simple benzodiazepine. And that too, even a spray is sufficient, because in your OPDs we don't have injections, needles, everything. We can keep a simple spray. Benzodiazepine is the frontline warrior, and don't underestimate its power. So as I said, the dosages are very important. So coming to the dose of benzodiazepines, what is the ideal dose do we give? We can give intramuscular, intravenous, intranasal. There are a number of drugs available, but there are two important medications which we see. First is midazolam and second is lorazepam. What is the ideal dose of midazolam? Just by heart it. Midazolam is 0.2 milligrams per kg and lorazepam is 0.1 milligram per kg, whatever is the weight. And there is a capping to the maximum dose. Why do we do not use the maximum dose of benzodiazepine in OPD? We are frightened that the patient will go into cardiorespiratory arrest, cardiorespiratory compromise, will need intubation, but that is not the case. If you follow this dose, follow the maximum dose, the patient will not go into respiratory depression. On the other hand, if these doses are not followed, the patient can land into status epilepticus, and that can cause cardiorespiratory depression. So please follow these dosages. Midazolam is 0.2 milligrams per kg and maximum dose is 10 milligrams. So if a patient with 50 kilogram comes, the dose is 10 milligrams, and we should not repeat the dose. If we are using lorazepam, the advantage of midazolam is it can be used through all three routes. It can be given intramuscular, which can be given in the OPD. In an actively seizing patient, you cannot put an intravenous line, so it can be given intramuscularly. It can be used intranasally also in the same dose, and intravenous also. Lorazepam is the preferred IV agent, but it can be given only in the hospital setting, and the dose is 0.1 milligrams per kg. But the maximum dose is 4 milligrams, and you can repeat it twice, right? So the maximum dose of midazolam is 10 milligrams, maximum dose of lorazepam is 4 milligrams, which has to be given. We usually give 2 milligrams, 4 milligrams, 5 milligrams, which does not make any sense. The seizure does not stop, and the patient is referred to a hospital. So please follow these dosages for benzodiazepines. I repeat again, 0.1 milligrams per kg for lorazepam, and the maximum dose is 4 milligrams. The dose for midazolam is 0.2 milligrams per kg, and the maximum dose is 10 milligrams. Just make it clear. So this is the OPD flowchart. I initially mentioned I will not be discussing flowcharts, but we have already discussed this. These are the lines of management in your OPD if a patient comes with active seizure. And the most important part in this slide is the dose of benzodiazepines. Coming to status epilepticus. So if this patient in your OPD, if the seizure was lasting, here the seizure was lasting for only 2 minutes. If the seizure was lasting for more than 5 minutes, it is status epilepticus, and the patient has to be straight away transferred to a hospital. Do not keep playing with the patient in the OPD if the seizure is ongoing for more than 5 minutes. Or if the patient seizure terminates, but he has again a seizure without coming to normal consciousness in between. So 2 seizures and in between the consciousness is abnormal. That is also treated as status epilepticus, and the patient should be referred to a hospital. Now I promised you that I will not be discussing definitions, but this one is important. Refractory status epilepticus. And why is it important? Seizures continuing despite one benzodiazepine and one anti-epileptic drug. If we give one benzodiazepine in the hospital, the patient has again one more seizure, the patient is referred to the hospital, and he has received one anti-epileptic drug. If the seizure persists beyond that, it is refractory status epilepticus, which will need further treatment. But note here, we are using only 2 medications, 2 anti-epileptic drugs, one benzodiazepine and one secondary anti-epileptic drug. Why is this? We'll come to it later on. So this patient was then referred to emergency room, where we again did the ABC, sugars, first line benzodiazepines, which was already given in the OPD. Then we came to anti-epileptic medications, which has to be given in the hospital. Here also the same logic applies. The loading dose of anti-epileptic drugs is very important. And what are these dosages? What do we usually give in your emergency room? What is the anti-epileptic drug preferred? You can shout out. Levipil, phenytoin anyone, valproate, carbamazepine. So all these drugs are most commonly used in the emergency room of the hospitals. But there are 3 main drugs which are recommended: Levipil, that is levetiracetam, valproate, and lacosamide. And the dosages are very important. Levetiracetam, what is the dose we usually give? 1 gram. But the ideal loading dose is 40 to 60 milligrams per kg. So if a patient of 50 kilograms comes to you, the loading dose would be 3 grams, which we hardly use. But that is the ideal treatment, and that is why 75% of status epilepticus patients are iatrogenic, because we do not use the right drugs, the right dosages. Levetiracetam, if it has to be used, it has to be given at 60 milligrams per kg, and there is no respiratory depression with these drugs. The second drug to use is valproate, and the loading dose is 20 to 40 milligrams per kg. So if a 50 kilogram patient comes to you, the loading dose is 2 grams. And this has to be followed. If not, the patient will land into status epilepticus. So make it clear once and for all, levetiracetam is 60 milligrams per kg and valproate is 40 milligrams per kg. These drugs dosages have to be followed, which we have recently started practicing in our emergency room also. So these are the only drugs which are to be given in the emergency room of the hospital. So we are done with the OPD management, we are done with the emergency room management. And that is all we deal with in status epilepticus. And treatment of seizures, beyond that is status epilepticus. So this is the ideal flowchart, and we have covered everything. The initial airway breathing circulation, checking the glucose levels, administering benzodiazepines, then in the emergency room, giving anti-epileptic medications in the correct dosages. So that is what is about managing seizures. Beyond this is status epilepticus in the ICU management. Now we have more than 25 anti-seizure medications available in the market. Which to use exactly? We have discussed only two medications which we can use. One is benzodiazepine and one is anti-epileptic drugs. So why do we need such extensive list of medications? So as you can see, there are a number of mechanisms of action for these drugs. Most of them have a single drug for a single mechanism of action. For SV2A we have levetiracetam or brivaracetam. For T-type calcium we have ethosuximide. For GABA agonists we have benzodiazepines. But in sodium channel blockers we have 5 to 6 different drugs. So there is phenytoin, carbamazepine, lacosamide, lamotrigine, topiramate. All this is theory and it is not useful. But why is this table important? So if we have a small door and we are pushing two fat people through the door, they won't go in, right? And that is the logic. Which drugs to be not used together? If we are using two drugs with the same mechanism of action, they are not going to penetrate the receptors. In fact, you are reducing the efficacy of two drugs using two drugs with the same mechanism of action. So in this chart, what will you do? You will never use phenytoin with carbamazepine. You will never use phenytoin with lacosamide or lamotrigine. But you can use valproate with either of them. You can use valproate with levetiracetam, valproate with benzodiazepines, valproate with any of the sodium channel blocker, but not two drugs with same mechanism of action. Will you use levipil and brevipil together? No, same mechanism of action. That is the same logic. So never use two drugs with same mechanism of action. Now you must have seen numerous prescriptions with patients with seizures having a list of 5 to 6 anti-epileptic drugs, right? So that is the common OPD practice. We have to use number of anti-seizure medications in OPD practice. But in patients with status epilepticus, this is a special case. We have two scenarios. One is a routine seizure patient coming to your OPD who is poorly controlled. We can use multiple anti-epileptic medications. But in a patient who is coming to your OPD or emergency with seizures, we have this guideline to be followed. And there is a very large paper. It's a multicentric paper which had studied the efficacy of drugs in status epilepticus. And here is the reason why we are using only two anti-epileptic drugs. The first anti-epileptic drug, the efficacy is 47%. But in second anti-epileptic drug, the efficacy drops down to 18%. And if you use a third drug, it is just less than 3%. And that is the reason we never use more than two drugs. You might say that okay, sorry. So you might say that 3% is still a big number. Why not use a third drug? That is because the efficacy is less than 3%, and in using multiple drugs who have very less efficacy, less than 3%, we are just depriving the patient of more effective anesthetic drugs. It's like a kindling. If you rotate a wheel, initially when the speed of the wheel is very less, it is very easy to stop the wheel. But when the wheel is in speed, it is very difficult to control it. So it is always better to stop the seizures in the initial part, and that is the time you have to use more efficacious drugs. So do not use more than two anti-epileptic drugs in the initial phases. If the patient is having seizures despite two drugs, straight away go to anesthetic medications. So you can have a photo of this. Why I was mentioning why levetiracetam is a poor drug. In all the three types of seizures, GTCS, focal seizures, absence seizures, valproate is the drug of choice. Levetiracetam is not useful in absence seizures. So if you do not have any knowledge of seizures, one drug which is to be used is valproate. What is the loading dose of valproate? 40 milligrams per kg. Okay, and that is the drug which is to be used in any kind of emergency. Now when we know the drugs, we should also know when not to use them, right? And that is where the contraindications are important. Young females in childbearing age never use valproate. But although in an emergency case where the patient is actively seizing, you can still use valproate as an emergency drug. You just do not have to continue it. But in young females in childbearing age, avoid valproate. In patients with psychosis, depression, suicidal or alcoholics, avoid levetiracetam. In pregnancy, only a few chosen anti-seizure medications are safe, which we'll be coming to. In arrhythmia, lacosamide is a strong indication. So these are the most important practical points where we have to avoid certain drugs. So which are the drugs which are useful in pregnancy? Oxcarbazepine and levetiracetam. These are the two most important and safest drugs in pregnancy. If a patient with epilepsy comes to you and has drugs other than these two medications, you have to straight away cancel them and put them just on these two medications, that is oxcarbazepine and levetiracetam. Any other drugs, they are not potentially safe. Many a times a patient comes to our OPD and they ask की 6 महिने झाले seizure आली नाही आता पण stop करायचे का औषध. So what is the ideal time to stop treatment? Seizure free period for at least 2 years in adults or 3 years in pediatrics. Underlying EEG should have been normal, right? If these two criteria are to be followed, seizure free period for at least 2 years and EEG should have been normal. Then can we taper the anti-seizure medications over the next 2 to 3 months. It has to be a gradual tapering, and during this tapering we have to monitor EEG continuously. We should avoid EEG or avoid driving or swimming during these 2-3 months of drug tapering, because that can be fatal. And always discuss the risk of seizure recurrence with the patients and the caregiver. So what are the conditions where the risk of seizure recurrence is high while tapering medications? If it is a longer duration of epilepsy, if there are multiple ongoing medications, if it is a syndromic epilepsy or the EEG was abnormal previously. So these 4 conditions, you have to be cautious before tapering the drugs. A few words about our favorite Levipil drug. There was a very big trial which is called as Sanat 2 trial, and these are the actual words from that trial. Since its approval in 1999, levetiracetam became love at first sight due to its broad spectrum, safety profile, efficacy, usefulness in pregnancy and tolerability. But all good relationships have their ups and downs. Sanat 2 clearly stated that valproate has more effective long-term seizure control and better 1-year remission rates than levetiracetam. So valproate also has a better side effect profile as compared to levetiracetam. The only area where levetiracetam scored over valproate was pregnancy safety profile. And this was the title of the trial. Dear levetiracetam, the honeymoon is over. So valproate is clearly more effective, safe, tolerable, cost effective, and less chances of treatment failure. But unfortunately, because of strong marketing, this drug has fallen back and Levipil is in the forefront. So I hope after this lecture, this is how we practice and control seizures. Right? So the take-home message is: choose drugs wisely according to the patient profile and the type of seizures. Benzodiazepines are always the first line. Levipil, valproate are the second line drugs. Always use benzodiazepines. Do not underdose with benzodiazepines. Use correct loading doses of anti-epileptic medications. Don't use 2 medicines from the same class of drugs. Do not use more than 2 anti-epileptic drugs in status epilepticus. Straight away go to anesthetic agents. And valproate is better than levetiracetam in all terms except the pregnancy profile. We'll have a short quiz. Are you all ready? Networks आहेत सगळ्यांकडे? Okay. Those of you who have them can vote in. Please scan the QR codes again. It will just take 2 minutes. We have a timer also. The faster you answer, the higher you will be in the list. I'm waiting for at least 15 participants. We have 3 winners. परत जॉइन नहीं करते Right, so we'll go ahead. We have 39 participants. So the timer is here. What is the loading dose of levetiracetam? 20 milligrams per kg per day, 30, 40, or 60 milligrams per kg per day? You have 20 seconds. Yes, unbiased quiz. Yes. So we have 35 votes. Last 5 seconds. Okay. 20% have paid attention to the lecture. So the right answer is 60 milligrams per kg per day. Levetiracetam, the loading dose is 60. Actually listening, yes. JP, who's JP? Oh, Jadip sir. Great. Baka, four questions remaining. What is the loading dose of midazolam and lorazepam for a 50 kg patient? Midazolam was 0.2 milligrams per kg. Lorazepam was 0.1 milligrams per kg. We have only two votes. Last 15 seconds. Midazolam 0.2 milligrams per kg. Lorazepam 0.1 milligrams per kg for a 50 kg patient. We have only 31 votes and 38% of the sorry, of the viewers has responded right. Dr. Ravindra Chaudhary sir, he is leading. Which two antiepileptic drugs will you not prescribe together? Valproate with levetiracetam, valproate with phenytoin. It is not carbamazepine with phenytoin or carbamazepine with levetiracetam. Remember, no two drugs from the same mechanism of action have to be used. Valproate has multiple mechanisms of action. Levetiracetam is SV2A. Phenytoin is a sodium channel blocker. Carbamazepine is also a sodium channel blocker. Last 5 seconds. Great. 49% have answered right. And let's see who's leading after the third question. Dr. Sushma ma'am. Coming to the fourth question, which is the safest recommended anti-epileptic drug in pregnancy? Is it levetiracetam? Is it valproate? Is it oxcarbazepine? Is it phenytoin? The safest drug in pregnancy. I had mentioned two drugs. One was levetiracetam. The second was oxcarbazepine. But which is the safest? Great. It's a mixed house. 41% audiences are right. It was oxcarbazepine, and Dr. Prachi is leading. The last question now. Remember, it also depends on how fast you answer because all of them have got 3 out of 4 right. This is the last question. A 50-year-old male with chronic atrial fibrillation, severe depression, has presented to ER in the post-ictal state after an episode of GTCS. Which anti-epileptic drug will you choose? Pay attention to chronic atrial fibrillation, severe depression, and generalized tonic-clonic seizure. Is it levetiracetam? Is it lacosamide? Is it valproate? Is it lamotrigine? Chronic AF, one of the contraindications. Severe depression, second contraindication. Very nice. So valproate is the drug of choice. And who's leading? Dr. Prachi is first. Dr. Yogesh is second, and Dr. Yogesh Patel sir is third. Come up. Please come up.